Welcome to this clinical walkthrough on the genital herpes in pregnancy case for the UK MLA, brought to you by Mediate, your 24/7 practice partner. We're going to break down exactly how you can ace this really important and pretty common OSCE station.
So, we'll be following a really clear 6-part structure that pretty much mirrors a real clinical encounter. This is your blueprint, taking you all the way from that initial hello to the finer details of management. All right, first up, setting the scene. You know, those first 30 seconds are absolutely crucial. This is where you build trust and really set the tone for the entire consultation. Your patient is probably going to start with something direct and anxious, just like this. And right away, this tells you what to focus on. The rash itself, of course, but just as importantly, her real anxiety about her pregnancy.
This is the kind of response you want to give. See how it acknowledges her concern, tells her she did the right thing, and gives that immediate reassurance? A simple sentence like this builds that rapport instantly and shows the examiner you're an empathetic, safe doctor.
Okay, let's move into section 2, mastering the focused history. Once you've created that safe space, it's time to gather all the key information you need. And the key words here are systematically and sensitively. Think of this as your mental checklist. You need to ask about the rash, check for any systemic symptoms like a fever, and then you've got to gently navigate the sexual history. Then, of course, you'll cover pregnancy details, past medical history, and allergies. And finally, you absolutely must explore her perspective using ICE, her ideas, concerns, and expectations. Hitting all these points shows a really thorough, structured approach. Now, when you get to sensitive topics, you can't just dive right in. You need to use signposting phrases, just like this one. You're asking for permission, and you're explaining why you need to ask. It's respectful, and it's a hallmark of a really professional consultation.
This is just a perfect example of how to explore that ICE. The first question gets right to her biggest worries. Is she worried about her own health, the baby? And the second question clarifies her expectations for the visit. Addressing these things is key to making your plan truly patient-centered.
Okay, you've got your history. Now you need to transition smoothly into section 3, the examination and diagnosis. This is where you connect the patient's story with what you can actually see.
Before you do a thing, you have to follow this protocol. First, explain exactly what you're going to do. Second, always offer a chaperone. This is non-negotiable. Third, make sure you're preserving her dignity. And only then do you actually perform the inspection. You need to say these steps out loud for both the patient and the examiner.
After the exam, you need to summarize your findings for the examiner, clearly and professionally, just like this. Using precise medical language here shows that you can spot the key clinical signs and link them straight to a likely diagnosis. Now you share that provisional diagnosis with the patient. You want to state it clearly and then immediately follow up with a simple, jargon-free explanation. This makes sure she understands exactly what's going on without feeling overwhelmed. Okay, let's move on to the big one, Section 4, the management plan. In an OSCE, having a disorganized, messy plan is a huge red flag. Structure is absolutely everything here. It shows you're competent and safe.
And before we break down the plan, just remember, knowing this in theory is one thing, but doing it under pressure is a whole other challenge. You can practice this exact case right now and get objective feedback on mymediate.com. Okay, let's get back to that plan.
This 6-point framework is your best friend. It's comprehensive and it's easy to remember when you're nervous. So, number 1, immediate antiviral treatment. 2, symptom relief. 3, specialist referrals, and that means both the genitourinary medicine clinic, or GUM, and the maternity assessment unit, MAU. 4, start talking about delivery planning. 5, address partner management. And 6, education and prevention. If you follow this structure, you won't miss a thing.
Next up, Section 5, counseling and safety netting. This is so important. Your duty of care doesn't stop when the patient walks out the door. You have to give them the knowledge they need to manage this and to know when they need to get urgent help. And this is where you need to be crystal clear. Don't just say, "Come back if you feel worse." You have to give them specific red flags. If the rash gets worse, if you get a fever, severe pain, or have trouble peeing. And critically, you must tell them to inform their obstetrician team about any new lesions near their due date. And this is how you want to end the consultation, with powerful reassurance. It's a great technique to kind of bookend the meeting this way. You're again telling her she did the right thing, and you're giving her a positive but realistic outlook. It leaves her feeling supported and confident in the plan.
And finally, Section 6. This is where you can really show off your knowledge, demonstrating that you can adapt your management plan based on clinical variables, like gestational age. Well, that's what separates a good candidate from a great one.
So this slide lays out the key difference. If the first infection happens before 28 weeks, you treat that initial outbreak, and then you restart suppressive acyclovir later on at 36 weeks. But if she presents after 28 weeks, you start her on continuous daily suppressive therapy right away, and you keep her on it until delivery. This is all about minimizing the risk of an outbreak during labor. Understanding this distinction is really critical.
And that covers our complete walkthrough for this complex OSCE station. But to really master these steps, you have to put theory into practice. You can do just that with this exact case over at mymediate.com. Thanks for watching.